But in any case, I think we can kick off now. Hi, everyone. Thanks very much for joining. My name is Kaja Jurczynska. I'm a senior technical advisor on HP Plus, working primarily on the family planning portfolio, doing some work in demographics as well. So lovely to have you all here. And today's session is on identifying and visualizing inequity in family planning programming. So let me know if the slides for any reason don't progress for you. I think they should. So I suppose we can just start with the existential question, why equity? I think we're all rights holders. Some of us are also duty bearers, but our right to health, equity in health and health care includes family planning. It's been cemented in countless treaties, declarations, rights instruments, and international conferences, and those consensus documents that have resulted from those meetings. So despite our rights, we have consistent evidence that duty bearers, including governments, ministries, healthcare providers, really aren't yet adequately respecting, protecting, and fulfilling our obligations. There have been many studies over the years really getting into the equity and inequity dimensions of healthcare services, including family planning. But in order for us to, get to a place of equity, we really have to understand where the pockets of inequity are and which subgroups are especially affected. And it's incredibly important to give that to give that information to decision makers so that they can use it in programming. So this is just one example. This is, of course, from Gutenberg adding it up. So what we see here is, of course, the number of adolescent women who have an unmet need for family planning. But I really think the message I want to get across here is the point at the bottom, which is that among women wanting to avoid a pregnancy, unmet need is much higher. Certainly, statistically, it's a statistically significant difference for adolescents than for all women. And that's just one stratifier, one way and one subgroup that typically experiences worse or kind of less ideal programmatic outcomes in family planning. So in response to pervasive inequity in health and family planning programs, we at HP Plus developed the Family Planning Equity Tool. And the purpose of the tool is, as you see here, to identify inequities in family planning for a diverse set of commonly disadvantaged groups. So that gets you to the who is being affected. Next, for various components of family planning. So that gets you to the what. So what in family planning is being delivered inequitably. And finally, the where. So this tool allows you to visualize the distribution of inequity at the national level and across within whatever are the predominant subnational regions. So effectively, the tool does the who, what, and where of an inequity analysis for you. And the results are intended, as I mentioned at the beginning, really for decision makers and programmers, people making choices about how we utilize our resources, where we focus our interventions, how we pivot our interventions, and so forth. And of course, the policies that we develop. In terms of what the tool is and where it's housed, thank you very much. The tool itself is code that is available on the HP Plus website. And it's code that would be used in our programming software. And for those who are unfamiliar, we provide step-by-step instructions about how to actually adapt and subsequently apply the code for a country of interest. And a country of interest can be any country with a demographic and health survey. So that's really beneficial because, those surveys are increasing and they have a lot of very useful information that we manage to leverage in this case for family planning. So a little bit about the methods. How does the tool actually work? Well, following basic setup in R, the code actually automatically runs for you, and it essentially does a number of statistical computations that test the experience of seven commonly marginalized groups of women. We'll get into those in just a second, across 5 components of family planning that we selected through a fairly rigorous process of investigating DHS indicators and thinking through what is the most representative measure of a different type of family planning component. And so through these statistical computations, if one of these subgroups has a significantly worse odds of receiving that component compared to a counterpart, that by our definition is an inequity. So if we go to the next slide, you can see the subgroups of interest. So here, we're looking at education. So we're comparing the least to the more educated, the youngest to older, poorest to richest, not married to currently married, minority to majority ethnicity, rural to urban residents, and minority to majority religion. We, of course, wanted to include many other stratifiers. Unfortunately, we're limited by the sample size in the DHS. So of course, disability would be an area of interest, but if there are only, let's say, 15 to 20 disabled respondents, then we're simply unable to actually include that as a stratifier, because we're not able to deduce whether that effect is statistically significant or not. So as the DHS becomes even richer and asks more background characteristics of respondents, we're hopeful that this can be expanded, or certainly for other equity analyses, you're going to be able to look at people's experience of services beyond just the groups that you see here. So that's the who. Now, what is the what in family planning? We've thought about not only looking at family planning outcomes, family planning use, uptake, unmet need, but we really wanted to try to understand what happens from across the spectrum. So we used AAAQ as the proxy for coming up with measures of family planning, the what in this case. So they're not perfect. It's also because, some of the questions in the DHS, well, if we could design our own access to information indicator, it might look a bit different, but this is what we have available. And of course, we need to work within what we have. So access to information is measured as exposure to any form of family planning mass media. So in this case, we would be comparing whether your exposure to mass media, whether it's different for the youngest versus the older, compared to each of the other stratifiers and background groups that you see above. Access to services, we've proxied as by the indicator whether you've been told of family planning by a provider at either a facility or by a community health worker. Acceptability is whether you are not using family planning due to stated opposition. That could be your own opposition. It could be as a result of familial opposition, partner opposition, and so forth. And then finally, we have quality in here. So for that, we use the informed choice index. So informed of method side effects, what to do if side effects occur, and other available family planning methods. And finally, we have a use measure in here, of course, and that's demand for family planning satisfied with modern methods. In terms of how you can use the results, and you'll get to see what the results actually look like, but we're hopeful that they can be useful at 3 different levels. On first level is, of course, at the level of policy. So if you're able to see where your pockets of inequity exist and who is most affected, that can support you in making a family planning commitment. And we did that a bit with FP 2030 and provided some analyses for 2 countries to support those groups and thinking through what their commitments can be to the initiative. The results can also be useful for prioritizing limited funds across program activities and geographies. So this can help you make a decision whether you want to prioritize it on, a mass media campaign, on actually kind of pivoting your family planning programs, on building greater capacity among the community health worker fleet to actually go door to door and sensitize people about family planning. So it can help you make those types of decisions within family planning program funding. And finally, it can actually help you better tailor and direct your family planning program activities, particularly at the subnational level. Especially if you see that there are some major inequities in some regions compared to others. It's a good tool for that reason. So let's have a look at some results. I think this is going to be most helpful. So this is specifically results from Uganda and Bangladesh. And we chose these two countries because they actually had very unique profiles of inequity. And you'll see what I mean now. So let's do a very superficial comparison first in terms of modern contraceptive use. So for married women in Uganda, that was exceeding 38% and growing. Bangladesh is a slightly different story. It's actually relatively high, but that rate isn't really increasing very much these days. It's fairly stagnant or constant. When we did the analysis, when we ran the code for each country using their latest DHS, we found that in Uganda, inequities in family planning were generally pervasive across the regions and divisions therein. Versus in Bangladesh, they were actually very, very much concentrated on a handful of regions, which you'll see visualized. The family planning component that was delivered most inequitably in Uganda was access to services. And you remember how that was proxied based on your exposure to family planning providers and community healthcare workers. And in Bangladesh, it's actually access to information, which is proxied by exposure to mass media. And in terms of the most commonly disadvantaged subgroups, in Uganda, that was the young and unmarried. And in Bangladesh, it was the least educated and the poorest. And there's some overlap between those groups. Of course, a lot of young women are unmarried and a lot of least educated women are also the poorest. What we've seen in some of our deeper analyses is actually the overlap there isn't necessarily as big as you may imagine. And so it's still important to target each of those groups and ensure that they have the services that they need. So Uganda, let's take a look at access to services. That's one of those family planning component measures. On the left-hand side, you just see the data straight from the DHS in terms of the percent of all women who were told of family planning by a provider at a facility or by a community health worker. So what does this show us? It shows that in the vast majority of cases, clients or individuals are actually not being told of family planning by a provider at either facility or community or at the community level. So overall, low levels, right? And that is actually further aggravated by the inequity profile that you see on the right. And this is a table that you can create using the results that come straight out of the model. There's actually a more rudimentary version of this table that is an automatic output for you. So you can even use that if you don't want to, beautify the presentation much more than what you're able to get in R. So focus your eyes on the columns. Where is the concentration of orange here? And you can see that in the case of Uganda, it's under youngest and unmarried. So when it comes to access to services, the youngest women in almost every single region experience an inequity in this domain, as do unmarried women. And you can see we have a bit more scattering of orange throughout under least educated, a couple ethnic minorities there, but really the takeaway message is that clearly the youngest and unmarried groups are experiencing the most inequitable outcomes with respect to access to services. So now let's go over to Bangladesh, where you see we're going to take a look at a different indicator. So this is, again, access to information proxied by the percent of married or in-union women who heard or saw family planning messages on any of the four media sources. And you have that as radio, TV, newspaper, and mobile. So it's actually a very similar story, but perhaps, worse than what we saw in Uganda. Very low levels of exposure to family planning messaging overall across Bangladesh. So, the highest is 22% there. It's really quite low. And again, that is aggravated by the inequity profile that you see on the right. So once again, focus your eyes on the concentration of orange in the column view. And what we see in this case is that the least educated and the poorest women are those that experience the worst outcomes when it comes to access to information. So in every single region, excuse me for the siren there in the background, every single region across Bangladesh, the least educated women have worse outcomes than their better educated counterparts, and the same is true for poor women compared to richer. So if we know these results, how can we possibly use them? So I think one takeaway message I was trying to zoom in on in that presentation is that the issue that is aggravated by widespread inequities in the case of Uganda is that women have poor contact with family planning workers, and in Bangladesh is that women have low exposure to family planning messages overall. If we were to think about addressing these inequities based on what you just saw from the analysis, there are a few options. In the case of Uganda, one may be, and this could require additional kind of contextual understanding of each country, of course, but building the capacity of facility and community health healthcare workers on family planning, sensitization, and counseling. Perhaps it's a matter of capacity, not having the right skill set. Again, this could be better curated if you truly understand the context. You talk to the Ministry of Health and others. So likewise, another approach to addressing the issue may be to ensure that healthcare workers have the skills and competencies to actually engage with the groups that you saw were most experience the most inequitable outcomes, because it's clearly the youngest and unmarried women. So maybe it's an issue of those healthcare workers simply not being capacitated and having family planning conversations and telling these subgroups about family planning. Maybe there's a level of provider bias that needs to be addressed. So there's quite a lot here to potentially unpack. And if you were then trying to target your outreach somewhere, it would really be focused on where the most disadvantaged groups reside. We saw where that was concentrated in Uganda. In Bangladesh, the story is a little bit different. So the emphasis on the approach can be more family planning mass media campaigns. The other takeaway then could be to curate your messages and access channels for those most disadvantaged, which was the least educated and the poorest groups. So maybe that means, mass media campaigns need to be in specific languages. Maybe they need to have both a kind of better visualization of the fundamental message, less text and things like that. And then the targeted outreach in this case would really be focused on ensuring that family planning mass media is accessible in areas where the least educated and poorest are concentrated. So if you'd like to access this code, it's available on the HP Plus website. And if you'd actually just like to run it already for one of 3 countries, you can download that code that has been completely curated. All you have to do is just download the DHS data, follow just a few steps, which are described to you in the code as well as in the manual. Hit process, and you'll actually be able to replicate the results for Nigeria across states, Uganda across regions, as well as in Zimbabwe. So thanks so much for your attention. We only have a few minutes for questions. Sorry for going a bit long, but welcome your reactions or questions if you have them. Thank you.
Thank you so much for that, Kaja.
Pleasure. Thank you, Vina. Or maybe I can ask, has anyone here done any equity analyses, or have you really investigated which subgroups of women in countries in which you work are experiencing the worst outcomes? Have you been using different methods or any insights that you'd care to share?
I can chime in. This is Tara Sullivan. I'm with Johns Hopkins Center for Communication Programs and the director of the Knowledge Success Project. And it's a little different than what you're doing, but we've also been looking at equity from a knowledge management perspective, which is the scope of our work, but using sort of similar framing to what you presented here, which is why I was interested to see how others are looking at equity, the AAAQ framing for that as well, but really just looking at it from the perspective of knowledge and knowledge sharing and that type of thing. So I think it's such an important conversation, and it's great to see how you all have addressed it here. So thank you.
Sarah, and I'll take a look actually. That's interesting for knowledge management, yeah?
Yes, for knowledge management. Yeah.
Super. Thank you. Well, I think we're actually supposed to move on to our next session. So I'm